good afternoon or good evening. It gives me a great pleasure to introduce Steve and his big day, great day. So Steve graduated in Birmingham in 1987 and served in the regular army, including the formal Yugoslav Union, and did his research in blast injury and gun shot wounds, and did his fellowship in the Royal Brompton, and then appointed at Hammersmith Hospital in 1998. So Steve is the president of the Intensive Care Society from 2014 till now, and he's the associate editor of the Critical Care, the immediate past chairman of the Intensive Care Foundation, director from Intensive Care National Audit and Center. My really interaction with Steve is really the good model of how the NHS and consultant should be in the academic health science center. He's a good clinician, a good leader, very good and excellent clinical trial and research portfolio, working very well with colleagues, helping colleagues to get grants, and that's why the recognition being a professor. So if we'd like really to have a model of how the NHS consultant should work in the academic health science center, this is Steve really represent a good model for that. So we are looking forward to see and to listen to you, Steve, and very really, hopefully, very good interaction with you both at the NHS and the academic health science. Thank you, Steve.
Thank you very much, George, for those kind words. And it's a great pleasure to see so many of you here this evening. And I'm going to tell you a few stories and talk to you a little bit about what we've learnt to people who've been looked after by ourselves in the intensive care unit. I thought I'd start off, we're in the home of science, so I thought I'd start off with a bit of art. And what we see here is Peter Bruegel's painting, The Triumph of Death, because sadly all of us one day will die, and this is an inevitability that we all have to deal with. And for the common people, it's something that they expect, and in many parts of the world it comes all too soon. And even if you're a king, it doesn't really matter. It's going to get you, no matter how much money you've got, it'll get taken, and the sands of time will disappear, and they'll get you in the end. And even some chaps at a dinner party are not immune from this, and there's a skeleton clearing off with all the booze, and and the band is being invaded by somebody with a lute. So death, unfortunately, is inevitable, but there's a time for it and perhaps a place for it. So where comes hope? So this painting is called The Raft of the Medusa, and it's in the Grand Gallery in the Louvre, for those of you that have ever been. This is on the back wall of where the Mona Lisa is. So the Mona Lisa you won't get to see and isn't very interesting. If you go around the other side of the wall, the Raft of the Medusa. And you can see here are some people gazing hopefully towards the horizon from where perhaps will come rescue. Now, Jericho was a thorough man, if nothing else. So when he was painting this picture, he had corpses delivered to his studio so that he could watch what happened to corpses as they decayed, so that he could get a more faithful representation of decaying flesh. And you can see he's captured that fairly well. The thoughts of his neighbors are not recorded. So here's a man with attention to detail that many intensivists would be proud of. This painting is a particular painting that I love. It's called The Doctor, and the Victorian artist. And he painted this at the commission of Henry Tate, who was the guy that gave us the Tate Gallery. And in fact, Files painted this in tribute to the physician who'd looked after his own child who sadly died. And what we see in this painting is, in the middle, the image of a child lying recumbent with the concerned physician sitting next to them. And just in the gloom in the background, you can see the concerned figures of the parents. And it looks a bit of a murky image, but I choose to see this as an optimistic image. And if we see through the window comes light, the light is shining on the child, and perhaps dawn's optimistic light is arriving, and the fever will break and the child will recover. So I see this as an optimistic thing, start of the future. Now, years ago, we started looking to see what had happened to our patients who'd survived episodes in intensive care units. And what we discovered fairly rapidly is that for many people, leaving the intensive care unit is not the end of a thing, it's actually the start of a thing, often something for which they're ill-prepared, and their families are ill-prepared, and quite often the people to whom we transferred the responsibility of the patient, they're not too prepared either. Just two thoughts, further historical thoughts. This is Florence Nightingale in the field hospital in Scutari. Now, Florence Nightingale understood the concept of intensive care, so she recognized the wisdom of gathering together the sickest patients in the same place. That way, they could accumulate expertise in how to look after those sick patients, and the staff would get more skill. And in many ways, that's the start of intensive care. More recognizably, we have this. So after the war in Europe, we had epidemics of polio. Many people had respiratory polio, they couldn't breathe, and they needed to be cared for in places like this, almost factory-level provision of something that resembles intensive care. So in these chambers, that people are receiving negative pressure ventilation because they can't breathe for themselves. And can you imagine lying in one of those things for an indeterminate period of time? There's one in close-up, spending months, maybe even years in one of those things. You can't survive that without any sort of consequence. Now, as it happens, it then became apparent, or soon became apparent, that ventilating people in these tanks, where we changed the pressure outside the chest, wasn't as effective as perhaps it might be. And what people learned from colleagues in operating theatres was that positive pressure ventilation, as opposed to negative pressure ventilation, gave better outcome. And that is really the start of where we have intensive care in Europe. Now, this is the sort of thing that we subject people to. So in amongst all that equipment is a patient. Somewhere in there is someone whose organs have failed and who's being supported with a respiratory machine, a kidney machine, in fact, 2 respiratory machines, because that particular patient is on what we call extracorporeal membrane oxygenation. So their blood is being spun out of them, spun through a machine to oxygenate it and take out the carbon dioxide. So can you imagine what it's like to be attached to that for an appreciable period of time? That has consequences, and that's the sort of thing that we're going to discuss this evening. Now, we used to think about the intensive care unit as a place, the sort of citadel right in the middle of the hospital. But over the last decade or so, actually, the concept of intensive care has spilled throughout the hospital. And now we regard intensive care starts at the point at which a critically ill person comes into the hospital and will continue throughout their stay. And increasingly, we're concerned with optimizing rehabilitation for people. In the UK, after the Second World War, there was a big rehabilitation medicine service, but it sort of dwindled, and we're having to fill that space now for many of our patients. We have to somehow help rehabilitate them. And many of us as physicians are not rehabilitation specialists, but we work as part of a multidisciplinary team, which is made up of physiotherapists and nursing staff and occupational therapists, speech and language therapists, all of whom are rehabilitation professionals. So we have to learn to work together as a team, and I'll come back to that right at the end. So what we see in this graph is a depiction from a study in northern Scotland of the recovery of patients after intensive care. So on the x-axis, we've got years, and what we see here is the recovery of what we call quality of life years, which is how the government likes to measure stuff. So here we have people surviving and accumulating what we call quality-adjusted life years. So not just being alive, but adjusting for that quality of life. And in the dashed line, that's the normal population. And you can see there's a big difference. So for people who get out of intensive care, they accumulate these quality-adjusted life years at a much slower rate than an age and sex-adjusted population. So that's a reflection of the toll of surviving intensive care has on people. Now, about 17 or so years ago, at Hammersmith Hospital, I thought I would start a follow-up clinic, and at that point, there was nobody really in a position to say no. So as there were empty outpatient rooms on a Friday afternoon, we set up an intensive care medicine clinic, and we're still there on a Friday afternoon, and there are still empty clinic rooms on a Friday afternoon if anybody else wants to do it in their own institution. Often that's a good time. Now, from talking to lots of people, I have learned a lot of lessons, and I've drawn this little Venn diagram about the sort of things that seem important to people during their recovery. So anxiety, pain, cognitive impairment, memories, social isolation. This guy here at the bottom right, perceived change in health, is quite important because it's the prism through which people experience recovery. So if you're an elderly person and your life is dominated by chest pain and breathlessness because you have aortic valve disease, say, one of the heart valves doesn't work, and you go into hospital and they fix your aortic valve, but it takes a couple of weeks to get over that, that might ultimately be a good thing, because if what you want to do is to spend time with your family and your grandchildren and be a positive part of that setup, that's a good thing. If maybe you're 28 and you come off your motorbike and wrap yourself around a lamppost and you end up with a really badly broken leg and you can't do the things that you feel define you, that is going to be a negative thing. And people will perceive everything about their recovery through that prism. Some people, paradoxically, have this experience and somehow they grow and they come out of this and they feel stronger having survived. And I met a good example of this last year, a gentleman who'd had an out-of-hospital cardiac arrest at Ealing Hospital. In fact, he arrested just as the ambulance delivered him to Ealing Hospital. He was taken in and they did the cardiac massage. They used the zappy thing on him, as my daughter calls it, and his heart started again eventually. But whilst his heart was stopped, a giant that they employ at Ealing Hospital was doing cardiac massage. And the people recognized that he was awake during this. And everybody was really anxious that he would have terrible, destructive memories of being awake and having this giant pressing on his chest. And he was sent back to see me in clinic early. And in fact, he was very philosophical about the whole thing. He recognized that the guy who was doing this was doing a good job, otherwise he wouldn't have remembered it, and that he turned his life around. Stopped drinking, stopped smoking, worked a lot less hard. This was a 32-year-old who'd had an out-of-hospital cardiac arrest because of coronary artery disease. And for him, the whole thing had been incredibly positive. Now, that's actually relatively unusual, but there is this concept called post-traumatic growth, which we need to acknowledge. Anyway, so there's my little Venn diagram. Of course, those things are very individual. So they're not going to work for everybody because people have individual things which are important to them, and we're not all the same. So I specifically haven't attempted to join any of those guys up. Now, people remember weird stuff when they're in the intensive care unit, really weird stuff. The most common delusional memory, as they're called, is of the nursing staff trying to kill the person. That's unfortunate, but it's true. But other stuff as well. And I keep adding to this list as people tell me stories of their experiences. The issue is that these things don't seem like dreams. So the brain mislabels these experiences, and they're nothing like a dream. They are experiences the same as a real memory, and therefore they can come back the same way a real memory does, because a memory of a dream seldom comes back. But a memory of something that the brain has labeled as reality can come back, and that can be a very erosive thing, especially if it's something nasty, like somebody trying to strangle you or trying to kill you. And we've had all sorts of stuff, drug dealing, the band. One guy woke up, thought he'd been abducted by aliens, was really disappointed when he discovered he was still with us at Hammersmith Hospital in Acton. The plane crashing one was a young trainee general practitioner who was with us last year, Sophie. And we didn't quite know why she was so disturbed by her experience with us. And then I talked to her in clinic. She had a delusion that she had crashed an aeroplane, that somehow she'd been on a plane, the pilot had dropped dead, she was elected to fly the thing, and she crashed it. And everybody else died apart from her. And she had this massive burden of guilt, which she was trying to live through. And of course, we knew none of this, and therefore weren't able to help her. And then, of course, there was one fellow, he spent his entire time with Beyoncé and was quite pleased about it, and somebody else was on a cruise. So there's a whole variety of stuff that people remember. As I say, some of it positive, some of it can be very difficult. When people leave the intensive care unit, they leave minus an enormous amount of muscle. So people who've been with us, they lose, if they're with us for more than the briefest period, 1 to 2% of their skeletal muscle mass every day. They lose that for the first 10 days in intensive care. And that's reflected in this slide, which is a classic study from colleagues in Toronto, where we see that people at discharge from intensive care here, they've lost nearly 20% of their body weight, and most of that's muscle. And that sort of recovers over the first year, but what recovers isn't necessarily functioning skeletal muscle. We don't really understand why that is, and we have no treatments to help with that. A great study from Zudin Puthacheri and colleagues at Guy's and Thomas's and the Whittington described this in real detail. So this is measuring muscle measuring the thigh muscle using ultrasound, and you can see here how it shrinks during the first 10 days after admission to intensive care. And they biopsied people's legs. And what you see on day 1, this panel over on the left, it looks quite nice, doesn't it? It looks fairly healthy. It looks like you'd imagine that muscle would look like. And then over here, that's a mess. That looks a little bit like the stuff that we give to Nellie, our cat. And that's the sort of thing that happens to people's muscles. And as I say, we have no way of accelerating recovery other than dealing with the underlying disease. And some of the trials that we've done to try and accelerate this have actually made people worse. But we don't currently have any drugs that we can use. But we have to recognize it's a big problem for people. And often they are surprised at how weak and how quickly they fatigue, even young people. And our colleagues don't understand this. So Catherine White, who works as the communications director for one of our patient support organizations called ICU Steps, she was quite young. She was in her mid-20s when she left intensive care, having had a very nasty infection. And she was so weak, she could barely lift up a cup of tea. And she had a small child at home that she now couldn't look after. And nobody told her that she was going to be weak. Nobody was able to help her. And it was only by accident, months later, that she found somebody that could explain to her that her experience was normal. Now, when we talk to people about their mental recovery, there's all sorts of things that they complain of. Memory, concentration, and this thing called cognitive function, which, to unpack a bit, is a mixture of memory, attention and concentration, linguistics and numerical skills, and the thing at the bottom is executive function, which is our capacity to take in information, follow rules, and somehow make the sort of decisions that we just take for granted. And we wondered a little bit about whether that was impaired in some of our ITU survivors. And as I'll show in a moment, it probably is. This study comes from Salt Lake City, and Mona Hopkins, who was the first author on this project, she actually was an ITU nurse, and then she retrained as a neuropsychologist. And she studied a bunch of people who had very severe respiratory failure, many of whom they were short of oxygen for quite some time during their illness. And what she noticed, if you see here in some of her results, was that just about everybody has some evidence of impairment of their capacity to think and make decisions. And at a year, for many people, that's still evident. So this only recovers really slowly. And lots of people have symptoms of anxiety and depression. So that's in one particular group. And then another group from Vanderbilt in the southern United States, they looked at a more general intensive care population. And they started off, they were ambitious. They had a big bunch of people, and they ended up only being able to do detailed research in a fraction. And that's important because lots of the research in this area is vulnerable to what we call enrollment bias. There's a reason why some people show up at our clinic on a Friday and others don't. Maybe some are back at work. Maybe some are so traumatized by coming to Hammersmith Hospital that the last place they want to come to is Hammersmith Hospital on a Friday afternoon. So all of this work is a little bit vulnerable to enrollment bias, and we just need to be a little bit cautious. But anyway, so in this study, done by a bunch of people whose main day job was looking after the mental health of the elderly, they identified that, using their testing, that almost a third of people had definable mental impairments of the sort that they were used to seeing in people with mild to moderate dementia, but this was 10 years earlier. So in their group of people, they found a problem. And then they did this sort of thing. This is called the Ray-Osterreich complex figure. and you show people this guy, and then they have to copy it, and you score how well or badly they do. And as I say, it's worth doing when you've had a very busy weekend and see how you get on. That's the sort of thing that they did. We did a similar study focusing on what we call executive function. So in this graph, T1 is 3 months, and T2 is 9 months after discharge from intensive care. And Kanika Sukantarat, who's one of our first PhD students within critical care at Imperial some time ago, she's now a professional clinical psychologist working in London, and she did this study with us. And the Raven is a thing called Raven's progressive matrices. That's the sort of stuff that will be familiar to many of you, including some of you younger folks at the back. It's the sort of thing that we do to test raw intelligence. The Hailing and the SET are tests of this thing called executive function. And all of these tests give an output of what's called percentage population equivalence. So they all give an output of 0 to 100. And if you score 100, then you're better than everybody else in the population. If you score 1, then you're only better than 1% of the population. And what you see here in these guys is a clustering of relatively low performance. So you'd imagine it should be fairly evenly distributed. It's not. Not in ITU survivors. They tend not to be very good at doing these sorts of things. So their executive function does seem to be down, and it doesn't seem to recover terribly quickly. Some people it does, others struggle for quite a prolonged period of time, and we're not terribly sure why. Lots of other studies have done this. Truly, what proportion of people have this, we don't know, but it is a pretty consistent finding, and this was from a systematic review we did ages ago, and we can see that the figure of cognitive impairment is somewhere between 20 and 40%, but we don't honestly know. But for some people, it is a big problem. And for those of us looking after patients, we need to bear that in mind. Delirium, when our brains don't work, seem scrambled, is something that we struggle a lot with in intensive care. And it's not just something that looks untidy, it has consequences for the patients as well, because it seems to be related to the long-term function of people's brains. And we can see in this study, if we look at this graph, along here we've got 3 and 12 months, and they've broken it down by age group, but we can see the ITU survivors have levels of brain function which is actually not far off a dementia level. So potentially quite problematic. And it seems related to the number of days of delirium. So what these guys did was they scored everybody to see whether they were delirious on a particular day, and they related that to their long-term cognitive function, and it was related. So delirium's nasty, and I'll come back to it. Lots of people, when they've survived a nasty thing, have anxiety and depression. That seems intuitive to us. And in our group of patients that we looked at with TAN, we use this thing called the Hospital Anxiety and Depression Scale, and anybody above the dashed line is defined as what's called a case on this particular instrument. So we've got higher levels of anxiety and depression than in the background population. Not everybody, by no means, but significant numbers of people have important anxiety and depression, and it's something that we all need to keep an eye out for. What about post-traumatic stress disorder? Well, I talked a little bit about these crazy delusions and hallucinations, or the memory of what got somebody into intensive care. So I saw somebody in my last clinic who 5 years ago came to us after her lungs filled up with fluid and what we call pulmonary edema. She had a disease called lupus, and it became very active, and her lungs filled up with fluid, and she has this terrifying memory of feeling that she's drowning. 5 years later, and she won't go anywhere now that stimulates the memory of that episode. She won't go on the tube, she won't go on a crowded bus. Any time she feels a bit breathless, it brings back this feeling. She feels herself drowning again, even though she knows that she's not. So this is the sort of thing that we call post-traumatic stress disorder, which we can talk a bit about later on if we have the time. But on this particular test, look, people who are over this line are scoring as cases on this symptom called intrusion. So if these memories are coming back, then that's what we call intrusion. And if people start making behavioral adaptations to avoid those stimuli, then that's called avoidance. So proportions of our patients have these intrusive phenomena, and their lives they alter to avoid them. So that's quite important. Now, this is a study from colleagues at UCL, and it's a great study. The reason why this is particularly a good study is that the dropout rate, as we call it, is very low. So Dorothy Wade, who's a psychologist at UCL, she established a relationship with patients on the intensive care unit and kept that relationship going. So she has a very high follow-up rate. And in her particular study, she identified that slightly more than half of people had evidence of psychological morbidity, those people that had stayed more than just the briefest period of time. So this is a good study, and there's great credit due for doing that. What about long-term outcome? And often people ask me, Doc, when do I get better? When do I stop recovering? Well, for many people, the recovery is measured not in days and weeks, as we might think from watching the telly. It's measurable in months and maybe years. So this is the group of people that you saw the weight loss right at the beginning. And we can see this is a test called the 6-minute walk test. And we can see that for the first couple of years, people's 6-minute walk test, which starts off disastrously, actually is improving. So it looks as if it takes a couple of years for people to reach a sort of physical recovery. And then this thing over here is a quality of life instrument, which you can divide the results up into mental function and physical function. And you can see that people's mental function seems to stabilize out fairly quickly, but physical function, this mirrors the 6-minute walk test. And people are still recovering for 2 years, and they may not ever get back to where they were before. But sometimes people get very frustrated about this, and I see people, particularly young people, who often very highly functioning, very driven people, and they set themselves unachievable goals, which they then fail to meet, and that sets up a cycle of potentially depression and unhappiness. And allowing people to recover at the right rate for them is a skill that we're only just beginning to learn how to master. So what can we conclude? Well, there's definite evidence that people have psychological problems, depression, anxiety, post-traumatic stress disorder. As I said, not everybody, but significant number of people, this is an issue. And it's very important that we try and get the message out so that our colleagues that take over their care are sensitive to these issues and that help can be organised for people. And we haven't got all the answers there, to say the least. Physically, all sorts of stuff, as you can imagine. Sometimes we can't fix the underlying disease. People's joints may get stiff. People have all sorts of stuff. This is one that's particularly interesting to us. Some people end up with problems with their trachea. Often they've had a pipe down there, a tracheostomy or an endotracheal tube, and they end up with breathing, which is a bit noisy. And sometimes people interfere with treatment of things like heart failure or angina because they think that it's stimulating asthma. And it's not actually. It's because there's physical trauma, scarring in the larynx, and what they really need is to be referred to colleagues in ENT surgery to have that dealt with, which often it can be simply. But actually what ends up is people, they end up being undertreated for their other diseases. They end up with their hypertension or their heart failure undertreated because it's being misdiagnosed. Right, what about everybody else? Well, when people do get home, often people need to be looked after. So members of their family become what we call informal caregivers. And you perhaps won't be surprised, even though we're just after National or International Women's Day, the vast majority of people who become informal caregivers are female. Not always, but the vast majority are. In fact, one of the most useful things I did a couple of years ago was for a guy who had been with us in our intensive care unit. He'd had pneumonia, he had a fit. He was a very upstanding engineer. He wrote to the DVLA in Swansea and said, I'm afraid I had a fit, I have to tell you, and they took his driving license away. He was the sole carer for his wife, and now a pair of them were now imprisoned at home. And I saw him in clinic, and I phoned up Swansea that afternoon, and by sheer fluke ended up talking to the chief medical officer at Swansea, at the DVLA, and I said to her, this is crazy, and she said, yes, I agree with you. And by that afternoon, I managed to get the guy's driving license back. It was the most useful thing that I did probably the whole of that year. But it is important recognizing this burden of informal caregiving. Now, years ago, we had no idea what the true social and economic consequences of being a critically ill patient were. There was some data from North America. We had nothing from the UK. And with colleagues in Oxford, we established this project where we ended up with a fairly large cohort of patients, and we followed their recovery, and we sent them out questionnaires, and we asked them, we collected data about what was happening to their family circumstances, and we learned some interesting and quite uncomfortable things. So what we see on this slide, the black line is where people were before they got sick, and then the middle line, the light grey, is 6 months, and then 12 months after intensive care unit discharge. And we can see here that, by and large, most people, one way or another, have income from employment. But if you get sick, then that disappears and you become dependent on state benefits. And that's rather unfortunate, to say the least. So there's clearly economic consequences for families of receiving home someone who's survived a critical illness. And if we look at family income, and the National Statistics Office divide people's income into bands for some reason, and what we can see here is that for a large number of people, their income goes left, it's reduced. So family economic security is impacted, particularly people who run small businesses, people who are self-employed, people who, particularly now, work in what we call the gig economy. Those families really suffer. In this graph, we asked people to tell us about whether or not they'd had to make any change in employment. And what we can see is that only 40% of people had managed not to make a change in employment. Other people had had to leave work, reduce hours, change job, give up job. So broad consequences for significant numbers of people, and our systems are not sensibly placed to help. And for those people that get into this mess, then navigating through the social security thing is something they're not used to, and there isn't an obvious way of helping them. So we learnt a lot from that. As I say, wasn't terribly comfortable, a lot of it. We also asked about how much care people needed, and a quarter of patients reported that they needed this informal caregiving, and that was quite persistent. And for those people that still needed care delivered to them a year, then lots of them needed more than 50 hours of care during the course of a week, which is a lot. So for some people, this is quite a big burden for them to live with, and also for their family to deal with. Now, when we published this study, we ended up all over the telly. Well, I did, making a fool of myself on breakfast TV. Now, one of the things which the journalists picked up on, which we hadn't, was the burden of pain that lots of people suffered. And we got these data from one of these questionnaires that we sent out. And if we look here, if you look at pre-admission, half of people have no pain before they got sick. Some people had moderate pain, but most people were in this group. Whereas actually, after intensive care, lots of people had transitioned from the no pain to the yes, I have significant pain group. Now, we didn't really twig this because we were focused on the money, but actually the journalists asking us questions drew our attention to this. And I don't know that we have structures in place yet to manage this properly, but it was a useful thing that we learned. Now, I want to talk a little bit about proper recovery now. And some of the next few slides come from Eve, who's sitting in the audience with you. Eve is one of our current PhD students, and she's been doing a lot of work on early recovery after illness. And I think some of the work which Eve has done is going to challenge the way that we care for people in intensive care. And I just want to share some of that with you. Now, one of the things which Eve and her colleagues developed was this thing called the Chelsea physical assessment tool. And it creates a spidergram here. So what you do is you plot functional assessments, and then you can draw yourself a nice circle. And as people get better, then it gets bigger. And if they have a relapse, then it gets smaller. And it gives people a score. And it may be something that family members would notice. And I think there are stories of people drawing to the attention of the staff the fact that Uncle Fred's CPAC score is smaller than it was last week, and then Uncle Fred, lo and behold, has some sort of setback. But the interesting thing is that if you look at the CPAC score of people when they're being discharged from intensive care, it sort of predicts where they're going to be long term. Now, when, as doctors, we discharge people from the intensive care unit, we look at them and we come up with some notion of whether we think they're resilient enough to survive on the wards. And they all broadly look the same, but they don't look the same to the physiotherapy folks, because they have a very, very intimate functional assessment of how people are doing, which is reflected in this CPAC score. And although the vast majority of these people will have looked the same to the doctors making the decision to discharge them, look, there's this clear relationship between the CPAC score and where people end up. So a functional assessment is really important and is not actually generally what we do. We do a crude resilience assessment, which we don't articulate very well, but the functional assessment, what people can actually do, working with the physios, to some extent is predictive of where they end up, where they get home with nothing, or whether they end up in a nursing home, or somewhere in between, or of course, never quite survive. And then there's a bunch of people that something nasty happens once they've been discharged. But that was a very interesting series of observations. Now, when we're trying to make people better, let's have a rehab program. That's great. So do we know how to measure the impact of our rehabilitation program? I don't think we do yet. This is a nice study which was done up in the Northeast. They subjected patients to a aerobic exercise scheme, and they tried to measure to see whether forcing people to exercise actually had a benefit. And when they were making measurements, they couldn't find any difference at all for all practical purposes. So their quantitative analysis didn't work. And we're sort of in Imperial, we are the spiritual home of quantitative analysis. So a bit of heresy. Here's a qualitative analysis. This is sitting down, talking to people, understanding their experiences. And the results here are completely different. So the qualitative analysis which they did alongside this study showed that people who'd been in the intervention arm, the people who had the new treatment, they felt better about themselves, they felt more engaged, they felt better supported, they felt emotionally in a better place to recover. It was hard to measure a physiological change. Here's another study, another really nice study from Edinburgh, where they added in a particular individual into their rehab team whose responsibility was to make sure that everybody got what they needed as part of their rehabilitation. And lo and behold, when they tried to measure an outcome, no difference at all. But when they sat down and talked to everybody and said, tell us about your experience, they did a qualitative analysis. There was a big difference between the two groups. The people who had been in the intervention arm felt better about things, felt more engaged, felt more cared for. It was a very positive study. Now, for many of us in this room, we've got to the point in our lives where, unfortunately, it's downhill all the way. So from your early 20s, the epidemiologists tell us, so there's a lot of people here that haven't got to that point yet, but from your early 20s, I'm afraid, your functional status gradually drifts down. Now, if you have a critical illness, then it goes down with a big bang. And then, if you're lucky, you recover up to the point on your particular decline. Now, not everybody gets a perfect recovery by any means. And there are some people where there is no recovery. We can't fix the underlying disease. And for those people, they may be on a persistent, accelerated decline. And then other people may have a relapsing, recovering illness, so somebody with perhaps rheumatoid arthritis or chronic bronchitis, then those people may have a sort of wobbly decline. And when we try to design our studies so that we can pick up the differences, we have to somehow acknowledge the different patterns of recovery. Now, what I'd like to talk to you for the next few minutes is a little bit about patients' experiences of recovery. And this is work which we had to add into Eve's PhD because of a slight issue that Eve had at a Christmas party one year, which resulted in a broken leg and a lot of Meccano stuck in it. So we weren't able to continue with Eve's original plan, and we added in a qualitative project to tease out the experiences of patients who have got into intensive care. And it has provided us with an incredibly rich source of information. So if you imagine that you're pottering along your normal existence and something happens to you suddenly and unexpectedly, then you disappear down a rabbit hole. Your conscious awareness of who you are disappears. And for a while, there is a black hole. And that might be a sudden event. It might be gradually drifting into a mess on a ward in a hospital, or it might be an elective admission. You come in for a nice operation, Professor Hannah wants to chop you up, and for some reason it doesn't go completely perfectly, and you end up in intensive care for a few days. And instead of waking up the following morning, you're waking up a week later. And that's not something you were anticipating. You weren't anticipating being hit by a bus. You weren't anticipating getting pneumonia. So your conscious awareness stops, and then when your conscious awareness recovers, you're in a completely different place. You're in a different place, you're in a completely unfamiliar place, and somehow your mind is trying to make sense of what's going on around you. And our minds, we live as humans, we live in a world of story, and we interpret the world around us with story, and our minds seek out story all the time. And if you're emerging from nowhere into an unfamiliar place with unfamiliar people, with unfamiliar stuff having around you, then rebuilding that story is a real challenge. Nevertheless, it's very important. And what I've put on the next few slides is some of the quotes from people that Eve's interviewed. And if you imagine yourself in that place, how you're suddenly, well, not suddenly, your brain is searching for meaning. And apart from the fact that you're physically very different to who you were before, but mentally you may be in a very different place as well, because your brain may not be working, may be scrambled by drugs, inflammation, who knows what causes all of this, but it's not very good. And this concept of delirium is something which really, really gets in the way. People, and as I mentioned earlier, people experience these flashbacks for a very long time, and they can be very unpleasant, and they can be the only thing that people remember about their time in intensive care. Some people remember nothing at all, some people remember actual stuff, and some people only remember delusions. And what we know from a really nice study which was done up in Wiston Hospital some years ago is that actually if you don't remember real stuff, then you're much more likely to have long-term problems, which is possibly one of the reasons why we now try and have our patients much more awake and much more interactive. Some of these delusions, as I say, can be quite critical. So here we've got somebody who was operating on Margaret Thatcher's cat, someone in Soho. They've obviously been to a Damien Hirst exhibition at some point, which I wouldn't recommend, having been to one. So people's experience is very strange, and some of it doesn't help in their recovery. Not being able to sleep, as we all know, is very erosive, especially if you're constantly uncomfortable. Being bored, many people get really bored, and they can't concentrate, so they can't do anything, because, as I mentioned right at the beginning, being able to pay attention to stuff and concentrating is actually quite a challenge for a lot of people who are in recovery. So just coming to rehabilitation, how do we help people to start putting their lives back together, even in the intensive care unit? And perhaps some of the things that we do in the intensive care unit don't necessarily help. Now, a couple of years ago, as part of a broader program with colleagues from up and down the country, we were trying to pull together a big trial, and some of the spade work we did was to get together a group of patients and their family members at the Royal College of Anaesthetists, and we sat down and we talked to them about their experiences and the sorts of things that they thought were important. We wanted to start our trial after discharge from intensive care, and they told us that we couldn't. They said that rehabilitation must start in intensive care, and it must start very early, because a lot of it is about harm minimization. So that's important. They pointed out to us that actually being discharged from different areas of the hospital, going from the intensive care unit to some sort of step down to a normal ward, these are big steps, and they're big, intimidating steps. Recovery doesn't necessarily have an end. The social structure around people is very important, and motivation is particularly important, because actually rehab is tough, and to be motivated to participate in that is a real challenge. And we also want to know how to engage people properly, and what do we do for the people that we just can't fix, or we can't deliver a perfect recovery, and we can't to everybody. How do we help them and not demoralize them and potentially jeopardize what recovery they can have? Now, lots of people are a bit confused about whether they had rehab at all. And some of Eve's patients were a bit confused about whether they'd had any rehab. They were a bit confused about what physiotherapy actually was. And for some reason, they quite like to have big physiotherapists. I think that's true, isn't it? They want great big strong people because they don't understand that actually physiotherapy isn't actually about force, it's about skill. And, but if you've never met that before, you probably don't know. And many of us come from a world where if force doesn't work, then you just use more force. And that is not the way that modern physiotherapy works. But patients, of course, don't understand this, and they're not in a position to take in the information. And the other thing that was interesting is that quite often they don't necessarily think the things that they're doing are important. So if you want to teach somebody to stand up again, and they've spent a month in bed, you can't just say, right, get out of bed. You have to break these down into little stages. And you break the stages down, and it might include sitting on the end of the bed. And then the patient succeeds in sitting on the end of the bed, and everybody's delighted, and there's lots of cheers and high fives, and the patient thinks, but that's ridiculous, because sitting up is not an important thing. I've been doing that for 35 years. They don't realize what they have achieved. And I don't think that we've yet worked out how to help people understand what their achievements are. And I think that's quite important, that actually when we break things down into little steps, patients know that they are actually making proper progress. Here we go. How do you applaud because I wash? That's idiotic. So people don't understand that they may have done something that's been quite good. So what about objectives for people? This is the Cheshire Cat. I'm not sure why the Cheshire Cat's lying on its sides, but it's still... or why it's wearing my socks. This is a fairly long quote, but do go through it right from the beginning. This is a concept about trying to help people by defining who they are and who they're going to be in the future. And the reference at the bottom, Marcus Aurelius, is quite an old reference now. And it talks about this concept of possible selves. Because for people to participate in a program to help them get better, then they have to work out what they can be. But they also have to work out who they are now and who they were before, if that makes sense. So if your consciousness is recovering in the intensive care unit and your last memory was running for a bus, then you still think that you can run for a bus, except you may not be able to because you've been in ITU for a week and you can barely sit up. So the first thing that people have to do, and we have to try and help them do, is to recalibrate who they are at that particular point in time, and then provides them with, help them find what their future self will be. So this idea of identifying a future self is really important. And this is a relatively new concept which Eve's been working on. And as I say, I think is going to develop into something that's really quite important. But people experiencing these things, we have to learn from them, I think, a bit better than we could before. And their experiences, I don't think, have been widely promulgated, and we'll get on and publish some of this soon. I think many of us find the concept of a tilt table quite frightening, even when we're well. So setting goals, so this is a classic part of rehabilitation, is that you identify goals for a patient, and then you try and work towards them. But if you're really unwell, in the early part of your recovery, you're not well enough to understand what your goals might be. And we have to make decisions for people. And then as they get better, then we have to have them as stakeholders in setting those goals. So actually there's this concept of recovering autonomy, which we'll come back to. And also people understanding exactly what they've been through and working out how they can build towards something in the future. So this is something that's called self-determination. And this picture comes from the website, which is at the bottom here. And I'm sure these slides will be available for people, and that you can actually watch the guy drawing it. And this concept of self-determination was originally articulated by two North American psychologists, Deci and Ryan. And they identified the importance of three things for helping people to recover their ability to establish self-determination. Autonomy, that is making your own decisions about things, competence, and relatedness. Three things: autonomy, competence, and relatedness. And you can imagine that for intensive care patients, before they go into intensive care, all of those things are firing okay. They're autonomous, they can do the stuff they want to do, and they relate to people around them and their environment and everything normally. And then in intensive care, that all stops. And then as they recover, then what recovers first? Probably relatedness. because they can't make decisions for themselves. They're not capable of doing anything. We all have to do that for them. So the first glimmer of stuff that's happening is people beginning to relate to the people around them. And we have to learn how to exploit this better, I think. So autonomy, competence, and relatedness. And relatedness is about people, not just us as staff, but also family members and visitors and other human stuff that's happening. And if we think about this, the way that we discharge people throughout the hospital, it's sort of like a descending staircase, isn't it? And as people recover, then the amount of paternalism that we impose on people gets less and should get less. Because as people recover, then their own autonomy should recover. But is there a mismatch between the steps in this staircase and the way we care for people? And it's possible that there is. So if we look on the list on the right, then there's all sorts of stuff that we do to people that may not help. So for example, something simple like brushing your teeth, which most of us take for granted. So if you're a recovering patient, it might take you 10 minutes to brush your teeth. But if the nurse does it for you, it might take 2 minutes. So sometimes stuff happens to people because it's quicker, but that may not be the right thing. And we might have to think a little bit harder about whether we ought to structure what we do to encourage people to do the things that they can do, even though it's inconvenient for us as caregivers in the intensive care unit. And that's something I'm not sure that all of us have completely hoisted in. And maybe we need to think about better ways of encouraging people to develop that autonomy, as well as developing their relatedness, but developing the autonomy, because all the other stuff may come along. And if we don't do that, then people won't be motivated. Because if we want to motivate people, we need to build these things together for them. So there's our descending staircase, and there may be little gaps where people aren't quite ready for the jump down. And some people might find those gaps very difficult and maybe challenging, and they may be very stressful. And countless patients and family members that we talk to actually describe these step downs as very, very challenging indeed. And perhaps we could do this better. So in summary of that particular bit, early on we have to stabilize people and stop them getting worse and stopping them dying. And then later on, perhaps we need to study how we accelerate their sense of autonomy, their sense of being a personal stakeholder in thing, and maybe help them find their future self at a point earlier than we have done before. So help find future self and help people engage in goal settings. And there's a final bit of Lewis Carroll, because people are definitely changed by that. Right, my final thing is about research. And this is the way that we decide on how we do research. This is the Wall Street Journal's approach to it. This is priority setting. So what we do from time to time is we work out what we're going to spend public money on doing research in the UK. And this is the old way of doing it, which was a smoke-filled room. This is the modern way of doing it. Nobody's smoking anymore. But who's missing? Well, the person that's really missing is the patient or the patient's carer. So in recognition of this, a thing called the James Lind Alliance developed. Now, not many of you will remember who James Lind was. Here's a guy who's not a stakeholder in any sort of prioritization. People are sawing his leg off, but he doesn't look as if he's really participating in a meaningful way. And I suspect he's not very interested in research prioritization. But these guys might be. So, remember I mentioned James Lind. James Lind was a naval surgeon, and he, at the time when he was in the Navy, and you can see this was the late 18th century, scurvy was a huge problem on ships because of lack of vitamin C. And James Lind became famous because he, by accident, did a thing that looked a bit like a clinical trial. So he gave some sailors citrus fruits, some he gave beer, some he gave seawater, and for some reason he gave a bunch dilute sulfuric acid. And not surprisingly, they didn't do very well. But the guys that had the citrus fruit did well. And that everybody hails as a very early clinical trial. In fact, people had done clinical trials even earlier than that. This is a guy called Ambroise Paré, who was a French barber surgeon who was working in the 16th century. So he was way, way before. And he in his writings, he describes, he was a military surgeon, and he describes going to the first siege he went to. And there were lots of people who had terrible wounds from missiles. And the standard treatment at the time, was to pour boiling oil into these wounds. And as a very junior surgeon at the time, Ambroise Paré was allocated a bunch of injured people and told to go and fix them. And they had slightly run out of boiling oil, and he couldn't bring himself to use it anyway because it looked so hideous. He wanted to do something different. So he came up with a concoction of oil of turpentine and a whole load of other stuff, which he used instead. He made himself some sort of ointment, and he distinctly describes in his book that being anxious because he knew that the following morning his new treatment would be being compared to the standard treatment of the time. And those of you that are clinical trialists will know that feeling of when you're waiting to analyze your results. And there's Paré in 1562, slightly before, waiting to see whether his treatment was better than what was the received wisdom at the time. Lo and behold, he writes, his people were all better. Everybody else was in a big mess, but the patients that he treated were considerably better. They'd slept well, they were pain-free, and everything was fine. He then went and spoiled it slightly by describing what he thought was the optimum treatment for gunshot wounds, the first stage of which was boiling puppies up in oil of turpentine. And so it was called oil of whelps, and it's a bit unfortunate. He was doing it quite well up until that point, but then it gets a bit off-putting. Anyway, so James Lind, clinical trial, lemons, oranges, that's great. So he was a trialist of sorts, and we established this thing called the James Lind Alliance. And the James Lind Alliance is designed to bring patients, family members, everybody that has a stake in a particular disease together and determine research priorities. So this is how we decide what we're going to do stuff on over the next few years. And we did this for intensive care, and we published it in the Journal of the Intensive Care Society. Some 800 people contributed. We ended up with 1,600 suggestions, which we had to whittle down to a final 10. In the end, we cheated slightly, and we had a final 11. They let us have a final 11. And these are the priorities. Now, the ones on the left of that list that are numbered 1, 2, 3 were the top 3. And we ranked those, and the others were just also ran, but were important. Look at this, though. How can patients be supported when they get home? The best way to tackle delirium. This is the thing, delirium. Patients hate it, their families hate it, we hate it as carers because we can't fix it properly. It's very frustrating, it delays people getting well. But quite a lot of the priorities that were identified by the whole community, including patients and their carers, are actually not front-end resuscitation, dangling out of helicopters, doing all that stuff. It's actually about helping to rebuild people's lives. So it's families, it's managing delirium, it's rehabilitation. How do we enhance comfort, physical consequences, psychological support? So although this may not seem as exciting as inventing a new drug or a new gadget, to the people, to our whole community, this stuff is very meaningful and something that we'll spend some time on. This is a slightly nihilistic depiction of intensive care survival by one of our colleagues in the States, Jack Iwashina, and he wrote this in 2010. Patients are ravaged, can't walk, can't think clearly, they suffer from PTSD. I think he'd obviously had a bit of a bad week when he wrote this, because I think many of us, and including some people in the audience, wouldn't regard it as bad. But it does make the point, if slightly heavily. Now, I've learned so much from talking to patients, and we talk all the time as doctors about patients being our best teachers. William Osler was perhaps one of the most famous medical educators in history some time ago. As you can see, these folks sitting around in Edwardian garb. There's Osler. Why there's a skull, I've no idea. I think, and they probably terrified this poor little child that's sitting next to it. Here's our MDT to finish off with Lewis Carroll. These guys look as if they're having much, much more fun. And although we deal with serious stuff in intensive care, it is really important that we actually have a positive approach to what we're doing. Because if we're all miserable as hell, then we can't really hope to get our people better and to push them forward. And I think that's very important. I need to acknowledge a few people. First off, Penny, who's in the front, who's my wife, and my kids who have to put up with a lot whilst I charge around doing these things. I've mentioned patients and patient groups. They've been incredibly supportive of this sort of work, giving up their time to help us understand what's happened. Many of my clinical colleagues are all sitting here as well, who have picked up the slack when I've been distracted doing research and trying to find out all of this information, and academic colleagues as well, in particular people like Tony Gordon, who's sitting in the front row, and Masao Takata, who've been incredibly supportive over the years. And various people have funded this work. This work doesn't attract huge amounts of money. I'm a shameless opportunist, so I generally can do quite a lot with very little money, but all sorts of people have one way or another managed to provide us with a little bit of money. Sometimes they don't even know they've provided us with a little bit of money, and that's just how I like it, because I was brought up in Liverpool, and we like to connive and get away with stuff. Thank you very much for your attention.
Sorry? There's no time for questions.
Okay. Well, they can probably find later when this with the drink.
Okay. Thank you, Steve, for a fascinating talk and insight into just the profound effects of ICU, and that it's more about just saving lives, the physical, psychological, social effects we have for our patients, but also the challenges, how we prevent it, and how we might treat it going forward. It's clearly a challenge, but also importantly, I think as it demonstrates as a clinical academic, it's more just about counting stuff in blood or doing trials and so on. It's about the patient as a whole, which has clearly come across in all of your work. When I was asked to do the vote of thanks, I thought, what am I supposed to say other than thank you? That was thanks, but there was a little guidance. It said, say how you first got to know Steve, and so actually it was quite easy to remember. He mentioned in the early 90s, I was just starting as a senior registrar, and I asked one of my bosses at the time, Hamish McClure, and he said, well, my advice is, he said, if you want to be an intensivist, he said, you've got to get a mentor, someone will back you. And he said, Steve Brett, he's a good guy, he's just finishing, he's just starting up. He said, he's the future of critical care in London. You would be wise to go and speak to him and see what he has to say. So Hamish was right on two fronts. You clearly were a rising star at the time, and have become a world leader in critical care, as you've demonstrated. But you were also an excellent mentor, and in more recent years, obviously, a good colleague. As we work together clinically and academically, I've always offered good advice and guidance. But you've also become a good friend over the years, whether it be discussing stresses of work and family life over a beer, or even coming around to have a look at your kitchen extension while we were doing the same at the time, so how things develop. It's clear that in the NHS and so on, it's challenging times ahead, with finances and so on, and critical care is going to be a problem. But I know, from a personal level, it's great having such a good colleague, but as an institution, I think having you as part of the senior leadership team within critical care at Imperial, the whole institution is in safe hands. So just thank you, and if everybody could just acknowledge Steve, thank you.
Thanks everybody. So this time now for the reception. Thank you.